Is it 7? Anand, shall we start?
Yes, sir. We can start, sir.
Okay. Good evening, everyone. My name is VK Kapoor. I am a professor of surgical gastroenterology at the Mahatma Gandhi Medical College Hospital in Jaipur. I have been here for last about 3 years. Before that, I had served the SGPGI in Lucknow for more than 3 decades. I am sorry that I may not be able to attend the entire session because I am currently in Chile and attending an international core group meeting for gallbladder cancer, which is my area of interest. So I may log out sometime in between, but my other colleagues will continue the session. Mahatma Gandhi Medical College Hospital is a private medical university hospital, a tertiary level hospital with 1,500 beds. We have almost all super specialty courses, DM and MCH, which are there in the list of the National Medical Commission. And we have a very robust kidney and liver transplant program. Now we are doing almost 5 to 6 liver transplants every month. And my colleague, Dr. Anand Nagar, is a member of the HPB surgery and liver transplant team. And he has also been handling this online educational initiative, which we started 2.5 years ago at MGMCH, Jaipur Surgical Tutorial. He has been coordinating all the activities. Every Saturday, 9 to 10, we conduct online classes for MCH and DNB students in GI and HPB surgery. And recently, we started a Jaipur Surgical School, which is on Friday evening, 3 to 4, because the students in Africa, they said that 9 to 10 Indian time is very inconvenient time for them to join. It's very early morning for them. So recently, we've started that every Friday. And then we thought that there are certain topics which are of interest to surgical students, and they need a kind of a capsule-like teaching on these topics. So we started these master classes, which are held last Thursday and Friday of every month from 7 to 9 p.m., 2 hours on 2 days, so 4-hour session. We've already done 4 master classes on living donor liver transplant, safe cholecystectomy, chronic pancreatitis, and what was the 4th one, Anand?
Acute pancreatitis.
Acute pancreatitis. So this month it so happened that both I and many of my colleagues are not in Jaipur because of conference commitments. And also I have been thinking about it. I've been talking to Anand about it, that how to manage a critically ill patient has to be the surgical residents also should know the basic principles. And that is why I requested the team of Anand and Ravi, who are the backbones of our transplant program, to organize and arrange this masterclass. And I'm very grateful to all the faculty who have accepted the invitation. RK, of course, is my former colleague from SGPGI, so he cannot say no to me. Thank you, RK. And I must also put on record the technical help provided by one of my other former fellows from SGPGI, Dr. Avinash Tank, who is now GI and laparoscopic surgeon in Ahmedabad. His technical team provides online support for all these online activities which we do. And all these sessions are recorded and they are uploaded on the Jaipur Surgical Tutorial YouTube channel. So with that background, I will hand over to Anand to introduce the coordinators, and then the coordinators can take on. Thank you very much.
Thank you, sir. First of all, thank you. And then I congratulate Dr. Ravi and Dr. Anand, who make us such a very good program for our surgical students, not for surgical, for every anesthesia and the critical care students. And this before making the program, we have discussed regarding what topics should we choose, and then we make a very simple topics, and they acknowledge all the topics to everyone and the great faculties we have for these topics. So our consultant with me, Dr. Ravi Jain, he is assistant professor critical care at Mahatma Gandhi Hospital, and Dr. Anand Kumar Jain, he is a assistant professor in Department of Organ Transplant Anesthesia, and he's with us for the our transplant patients, not for the transplant, for the pre-operative workup of the patient in the HPB ICU. So I hand over to Dr. Ravi Jain and Dr. Anand Jain for the further starting of this our Jaipur surgical tutorial. Dr. Ravi.
Yeah, thank you, Kapoor sir. Thank you, Dr. Anand, for this formal introduction. Without wasting much of time, I would like to introduce our first effort. First of all, we made this with common consensus between me and Anand and Kapoor sir. Obviously, Anand Nagar was also involved in making the topics. We requested many faculties across the nation and could pull out some very active members of critical care fraternity from across India. So we are presenting surgical critical care masterclass, the fifth masterclass of Jaipur surgical tutorial to you. Yeah, thanks again to our patrons, and I'll hand it over to Dr. Pankaj Anand. Dr. Pankaj Anand is a chairperson for this particular session. For first two talks going to happen over here. Dr. Pankaj Anand sir is head of the Department of Critical Care Medicine as well as Internal Medicine at Fortis Hospital in the city of Jaipur. Dr. Pankaj Anand is a very active critical care physician in our societies, in our fraternity. He is a former secretary of ICCM Jaipur branch also. Dr. Pankaj Anand is a avid learner as well as a very prolific speaker and teacher. I'll hand it over to you, Dr. Pankaj Anand, sir. Dr. Sir also has a very unique initiative of ACE Academy. I wish to learn him from, hand it over to him, and he will introduce our speakers from here on. Sir, please.
Good evening and welcome. Let me first thank the entire organizing team, Dr. V.K. Kapoor, sir, for having the vision and the wherewithal. I'm practicing critical care for the last 23 years, and most of the surgery people leave the patient to the care of the critical care guys once at the door of the ICU. So it's very interesting and encouraging to realize that the surgeons are now actually learning the intricacies of critical care, which is no more a domain of the physician. We all are equally should be informed and involved in the process of decision making. Now, about today, we have some very interesting topics lined up for this. And the first speaker is my old friend, Dr. Yash Javeri. I've been following him for the longest time that I am in the critical care. He's one of the most active, prolific person, not just in the field of critical care, but also he has a unique quality of bringing everyone on a common platform. He's a big player on the scene of the Indian Society of Critical Care Medicine, and not just in India. He is a well-known personality across the globe. His core areas of interest, as you can see, are sepsis, antimicrobial stewardship, ethics, trauma. He has a huge list of educational achievement. I don't think to us critical care guys, he needs any sort of an introduction. And as far as the surgeons are concerned, you'll get an introduction once he starts speaking. And he's going to speak on a very, very interesting topic. What happens when do you involve the critical care team? Once, when there's a surgeon involve a critical care team, what should be the rapid response even before the critical care guys come in? So you have a patient, either you operated or he's come to the ER and you are there. And what are the important points that you should know? And how do you decide whether this guy needs ICU care or not? This is, sounds very trivial, but this is a very, very important decision. And of course, this can make a difference in the life and death. So I now invite Dr. Yash Javeri to please speak on rapid response and critical care outreach. Who goes to the ICU? Dr. Yash.
Thank you, Dr. Pankaran. Thanks for the kind word and introduction. And at the onset, I'd like to thank Dr. Kapoor for a very noble initiative, much needed. And we all understand that critical care, although it is practiced within the walls of critical care ICU, but it happens everywhere across the hospital. And in smallest intervention by a nurse, by a surgeon, by a medical officer can change the outcome. So we will play the presentation. Thank you.
Good evening, friends.
At the onset, I'd like to thank Dr. Kapoor sir and my dear friend Dr. Ravi Jain for the kind invitation to Jaipur Surgical Tutorials, a very innovative initiative, and I'll try to do the justice to the topic. My topic is rapid response team or medical emergency team, whatever you want to call. This is a part of critical care outreach. Who goes to ICU? So the talk is around the sick patients in ICU who are called by rapid response team and what is our input at that time and who goes to ICU. Rapid response team or medical emergency team can be changed used interchange. So goals of this talk are to understand the early identification and assessment of signs and symptoms of critical illness. A stitch in time saves 9. Time is essence, time is life. We all know that. We'll discuss the significance of early medical intervention. We'll discuss how to cut down the long process of calling and how to fast track the process of the right healthcare provider reaching the bedside in a very, very short time span. We'll emphasize the principle that resuscitation and assessment should occur horizontally. We'll try to emphasize on ICU admission criteria and will dwell upon rapid response team the role. We all know what we have sick a lot of patients nowadays, surgical patients by virtue of their disease, major surgeries and other interventions are little serious patients, and often they can go in a life-threatening condition. This demands early recognition and intervention. A small intervention can save the patient, and it can save a major intervention which could be required later on. Treatment and search for diagnosis should occur simultaneously. Can we predict which patients will require ICU and which patients are seriously ill? Yes, there are some tools like emergency admissions, comorbidities, advanced age extreme, I would rather say, prolonged hospital stay, malnutrition, immunosuppression, severity of illness, post-anesthesia, bleeding, rebleeding, massive bleeding, prolonged bleeding, even small amounts, drug or alcohol dependencies, some scores like Apache 2 or injury severity, and many other scores, clinical course of the patient. This is most important, and the lab parameters. So yes, there are some tools to predict, but at times patient can deteriorate without any red warning signs. So what are the calling criteria for medical emergency team? Any serious deterioration, it could be airway, breathing, circulation, bleeding, neurological deterioration, or a simple thing like something is wrong with the patient and I cannot pinpoint what is wrong. And this happens with all of us. Even after a day or two, we are not able to pinpoint at the problem, but we know that something is wrong. So such patients and patients who have these physiological perturbations, they require urgent attention from a rapid response team. We can again classify them A, B, C, D. E, airway issues, airway compromise, breathing becomes striatus, breathing respiratory arrest, tachypnea, bradypnea, respiratory acidosis, circulation like cardiac arrest, hypotension, uncontrolled hypertension. We generally follow again this ABCD approach, and this approach we have to follow always. Airway, breathing, circulation, disability. E is exposure, E is evidence, and E is focused examination. Immediate investigations and appropriate monitoring should be initiated as soon as we recognize a life-threatening physiological disturbance. We might not be able to diagnose pinpointly that what is the problem. But if we say a patient is hypoxic, we have to give physiological support till we arrive at a fixed diagnosis. Many of these critically ill patients will get help with oxygen and fluids, but again, we have to tailor it according to the need of the patient. We can also use this direct methodology. D is for detection using the history, physical examination, cardiovascular respiratory examination, ultrasound at bedside. Then we do intervention depending on the cause of the problem. Intervention, once we do the intervention, whatever the problem is, we have to reassess the patient. Effective communication is always
required, especially in times of crisis. The greatest source of injury and death in healthcare is poor communication. The more complicated the patient, the more important it is for everyone to communicate their perspective to the team. And you have to respect everybody's input, more so in crisis. Delegate the sensitive task and ask for completion. And yes, teamwork makes dream work. Also in crisis, it might be rapid response team, code blue team, Crimson code, whatever code we talk about. Teamwork is must. Surgical patients who require critical care, they are more challenging, they are more precious. The anatomy is altered, the physiology is altered. Surgical insult has already happened. It's a sort of trauma. We all know that. There could be surgical and non-surgical causes of illness and deterioration. We have to always remember this. Always remember that do not work upon pre-packaged diagnosis. Always give a fresh look to the patient when you arrive at the bedside. Initial workup should be towards physiological diagnosis rather than a fixed diagnosis, which is the final diagnosis. Look at the charts, look at the physiological trends, recent and past surgical history, lab and ancillary testing as and when required. Most of the time, an arterial blood gas tells us what is required. Surgical patients might require ICU for the illness, for the severity of illness, for monitoring, for bleeding, for respiratory issues, for thermal disorders, metabolic acidosis, respiratory acidosis, for coagulopathy, or for monitoring at times. I'll give you a case scenario. This guy you find on the roadside. What are your priorities? Think in your mind. If you have thought anything except ABC, you have thought wrong. So ABC will always come first. However ghastly or fascinating the injury or problem looks like, always focus at ABC. If you do this, all your patients are going to improve. Speed is life. If you are slow, you lose the patient. Another dictum, there is no surgical or medical disease, especially in court situations. So work towards physiological diagnosis and stability. Do not be bravado that I can do this. This cannot happen to me. Always work as a team. Denial. Never be in a denial. This cannot happen. Medicine does not work like this. Anything can happen. Sorry to say, but surgical colleagues, especially, they will always say bleeding cannot happen. There is no surgical issues. We have to come out of that mindset. Work towards your thoughts. Involve the specialists, get a scan, get other specialists involved. And if you find the problem early, the solution will be early and easy. Acknowledge the issues, respect the inputs from other colleagues, even from the nurses. Critical care is not a location. It is a level of care and expertise that seriously ill patients require. This was said by Sir Peter Safar, his father of resuscitation. Why is there need for rapid response team? We are already in hospital. Patients are being monitored, but the risk of death in hospitalized patients is huge. We have sick a lot of patients in the wards. And our code blue reviews everywhere on the globe showed we had 24 hours or more to look at the deterioration, to give our inputs, but we failed. That is why this rapid response team or code blue team arrived. There's constant need to improve and excel, accreditation required, and we want timely, swift care to arrive at the bedside when the patient requires it most. The cycle should not be a prolonged cycle with lot of red tapeism in it. Resident, nurse calling, resident calling, consultant calling, the HOD calling, the consultant back, then consultant calling, the ICU director calling, the duty. It should be fast, and we have to cut across all these redundant pathways. So where were we failing? We were failing in planning. Our assessments were poor. Assessments were often ignored or poorly done. Failure to communicate, patient to staff, staff to staff, staff to physician. Failure to recognize deteriorating patient condition, because the healthcare provider could be stressed, there could be burnout, it could be late in night or early in morning where the reflexes are poor. So we are sitting on a burning platform and patient's life were at stake. So we have to cut down upon this redundant pathway, what we talked about. This traditional system is prolonged. We have to make it a fast-track system. Patient deteriorating in ward, nurse, medical officer, frontline healthcare worker does a rapid response team. The rapid response team member arrives. They give their input, and if required, the patient is shifted to H2 or ICU, whatever is required. So the calls for sick patient will no longer be delayed. The complicated call process is out. Ward patient will get a swift care with a whole lot of team. And this is how the RRT works. This is from the first consensus conference on medical emergency team. In patients with sudden critical abnormalities in vital signs, a failure to react promptly or commensurately escalate care constitutes a failure to rescue and may result in a serious adverse event. So, it is not only failure to recognize, but failure to escalate care also, which constitutes failure to rescue. If your hospital, your team is not able to escalate care, you have failed in your duty towards patient. So what is the composition of RRT? RRT composition depends on your local HR. It depends on your local context. Intensivist or intensivist, senior intensivist or senior medical officer who is looking at the ICU, emergency physician, critical care nurse, team leader of that particular area. These are the key members generally, but intensivist or anesthetist or physician can be used interchangeably. It purely depends on what resources you have. But even small centers like 40, 50 bed, we are able to do a good RRT team and we are able to save lives. So whatever size of hospital, primary, secondary, tertiary, RRT team is must. What are the key features? They should be able to respond immediately when called. They should be on-site and accessible, and they should have basic critical care skills like intubation, resuscitation, a big IV access when required. So these are basic skills which even a critical care nurse or a medical officer or an emergency medical officer possess. So your team should be in place, whatever level of healthcare setting you are working in. Aim, as we discussed, is early intervention and stabilization, prevent of arrest situations, and decrease in code blues which are occurring outside ICU. This is our old hospital, looks very, very complex, but to simplify, patient deteriorates, the nurse or the medical officer notices it, whoever is the frontline healthcare workers, they call the code blue, you have a dedicated number which goes to the exchange, and there is an announcement, code RRT on second floor medical floor, room number 204. And the rapid response team rushes to the center. You can see the team constitution is different at different centers, what I was trying to stress upon. So RRT teams arrive within, say, 3 minutes. It could be even smaller in smaller health setups. They assess the patient. They stabilize their patient. If required, they shift the patient to ICU after stabilization. They assist with transfer and communicate with the primary team, and they educate and support and counsel the family as well. So we follow this SBAR communication tool. Suppose I am doing a RRT. I am in room number 204. Now suppose I am calling the RRT. Hello. I am Dr. Yash Javeri speaking from room number 204. Patient Mrs. Vinoda Sharma is having tachypnea. Her respiratory rate is 35. Patient was admitted for cholecystectomy, and my assessment is that you should be calling an RRT and it should be urgently attended. Thank you. The exchange person, it could be even smaller. The exchange person calls RRT room number 204. That is it. And the whole team arrives. Background, you have to look at reason for patient assessment, ABCDE assessment. What the problem is, why are you worried, and what is your recommendation? What do we need to do? So this SBAR model of communication, although I am discussing it in RRT, but this has to be communicated for all healthcare communication. tell the situation, tell the background, your assessment of the problem, and what do you recommend. But for RRT or code blue, it is not such a prolonged communication. It is very, very small. Room number 204 RRT. But otherwise, you should be following this whole section. Another important thing. Once you go and see a patient, you have to tell the senior at time. Utilize this tool. CUS, concerned. Patient's little tachypneic 25, I am concerned about my patient. Patient's saturation is now 90% on 5 liters. I am uncomfortable with the situation. Patient is breathing very, very fast, tachypneic, his saturation has dropped to 80. The safety of my patient is at risk. So whenever you communicate, always follow this tool in your SBAR model. SBAR briefing with utilization of this CUS statement. This will make your communication more strong. And the role of subjectivity will go away. You will convey a very, very crisp message to the concerned person. I am concerned, I am uncomfortable, safety is at risk with the SBR model. Documentation, whatever you do, this is a RRT form. The reason for call could be varied. Just a simple reason could be the patient does not look good. I am unable to pinpoint the reason. Or bradycardia, tachycardia less than 50, 130, systolic blood pressure less than 90 or more than 180. Acute blood pressure changes, low or high, bradypnea, tachypnea, significant bleed, altered mental status, sudden loss of consciousness, new focal neurological deficit, worsening hypoxia, oliguria, chest pain, critical lab values. So these are the triggers. Then you write the situation, you write the background, your assessment, and your recommendation. Physician read airway, patient needs intubation, patient needs defibrillation, and you notify the treating consultant. So this is about the SBR model, CUS, and the rapid response team call. Now, the team has assessed the patient. Not all patients will be requiring ICU admission, but many of them will require. Out of, say, 100 RRTs, almost 40 to 50% of them require ICU or high dependency unit. Which patients will require ICU? Critically ill patients who have organ dysfunction, like hypoxia, oliguria, who require intensive monitoring. Life support, like ventilation, BiPAP could be at the ward or in the SDU or ICU. Invasive hemodynamic monitoring, arterial or a CVP, ECMO, pacing, defibrillation. These patients are obviously requiring ICU and they are priority 1 patients. Where priority 2 patients, these plus patients who have lower probability of recovery and less likely to receive intensive care therapies. These are generally palliative care or end-of-life care support patients. These patients, you have to make a judgment in consultation with the primary admitting physician. If the physician feels the patient should be in ICU because he has been talking to the family, you admit to the ICU, otherwise the patient is monitored in the ward. So these are the basic indications for ICU admission. It could be intermediate medical unit also. The indications for ICU admissions would are airway, breathing, circulation issues, hypothermia, hypothermia, bleeding, coagulopathy, any organ support which is required, any invasive monitoring which is required. Now you have launched the RRT. It takes time to be effective. How do you look at the effectiveness of RRT? Did you decrease on the code per 1,000 discharge? Codes outside the ICU decrease. Number of unplanned ICU admission from ward, did they decrease? What was the utilization of the RRT? What is the mortality in your RRT patients? This is a 2x2 matrix. This is from IHI, Institute of Healthcare Improvement USA. Box 1, patients admitted in ICU for active treatment. These are the right patient which have to be admitted in ICU. Box 2, admitted to non-ICU patient for comfort care only, like a patient with CA, pancreas, and metastatic disease, admitted in ward for comfort care. Again, this is right. Box 3, I will show you the boxes in the next slide. Admitted to ICU for active treatment. This is also right. Whereas box 4, admit to a non-intensive, admit to ICU for comfort care. Patient who is not requiring ICU is admitted to ICU for comfort care. This is a wrong patient. Okay. And patients who are requiring active treatment, patient in shock, admitted to ward, again it is wrong treatment. So your site of care should be very, very clear when you are shifting the patient from emergency or from operating theater. If your site of care is wrong, it will be problem. Comfort care only, you should not be admitting in ICU. Okay. Yes, comfort care only, ICU admission again wrong. It should be in the ward or in a palliative care ward. Whereas if the patient requires active treatment, patient should be admitted in the ICU and not in the ward. Active treatment, ICU, non-active treatment, ward. Palliative treatment, ward, not in the ICU. So, these patients, which patients? Patients requiring active treatment, but they are admitted outside of the ICU. It could be from the emergency, it could be from the operating theater, it could be from the ICU. You shift the patient to the ward and say after 24-36 hours, you recognize that there is a problem. Patient might require a readmission to the ICU. This is the area, this is the opportunity for application of the rapid response trigger 2. And this is where you can bring down the mortality drastically. This is again the campaign from IHI. This is about 15 years old, 5 million lives from harm. You have to protect these many because these many patients were dying in US from iatrogenic injury or from failure to resuscitation. The tagline which they use, some is not a number, soon is not a time. Every life counts. So any RRT, it could be a futile RRT, it could be wrong trigger and patient could be well, but do not discourage such RRT, especially in the beginning. Respect those RRTs. One wrong RRT does not cost you anything. But if you miss on an RRT for a critically ill patient, it could cost life to the patient. So some is not a number, soon is not a time. Every life matters. If you are concerned, so are we, call RRT. Now, people are going even farther. Family triggers. Family looks at the patient, not for India probably right now, and finds something grossly wrong. There are systems where there are triggers from home. Pediatric triggers are different, obstetric triggers are different, medical emergency, warning signs, modified early warning signs are different. Whatever, you have to establish simple process for activating the rapid response team. You have to brief your team, plan, practice RRTs. Once you're not able to arrive at a problem, do a brief huddle, discuss amongst yourself or call for help as we discussed. And after every RRT, do a debriefing, what went wrong, what went right. This is an opportunity to educate the ward nurses, the ward MO, the primary consultants. Look at the root cause analysis. This is an opportunity to improve your quality of care. Do audits and peer reviews of RRTs and code use. As we discussed, this is the future of RRTs, early warning scores from the monitor, computer-generated early warning scores, computer-generated codes, fully automatic versus semi-automatic, the time will call. Whatever model you apply, the simpler, the better. Slowly, there will be hitches because there could be fake calls. But slowly and eventually you'll start to love it, especially the RRT team members, the intensivists and the nurses, because you have an opportunity to save lives and for which probably we became doctor. This is what we published. This is a very old article we published from 2014 International Journal of Critical Illness. Evaluation of rapid response team, implementation in medical emergency, a gallant evidence-based medicine initiative in developing countries for serious adverse events. The background was RRT being implemented in developed country with aim of early recognition. We took data for about 6 months and the outcomes were studied. I will straight away jump to the conclusions. Implementation of RRT in this hospital was as well with reduced code blue events and its attendant mortality outside the ICU settings also decreased. but it was a small study because our numbers were small, only 41 RRTs. Tips when getting started: no call is a bad call. Do not be punitive and criticizing to the nurse or the medical officer who gives a wrong call. It happens. Initially and continuously communicate. You cannot do enough of this. Be systematic and relentless with your communication. Share the success story, review the failures of RRT, and do a huddle and debriefing after every RRT. Take this an opportunity for education of your nurses, of your medical officers, and other healthcare providers. If you are concerned, so are we. Call RRT when required. So what have we learned? Some is not a number, soon is not a time. If you are concerned, so are we. What is concerning now can be life-threatening later. Eliminates barriers to calling for urgent assistance and call RRT. Thank you. I will invite questions and comments.
I think the next speaker is Dr. Geetesh Mangal. For most of us in Jaipur, he is a very well-renowned speaker, practitioner, a very humble guy. I have known him for many, many years now. He's been practicing critical care for more than 10 years. He loves tele-ICU. Actually, he is at the moment working as director in the Department of Medical and Clinical Operations in a unique initiative called HOPE, which provides tele-ICU to a lot of hospitals in and around Rajasthan. He has many publications to his credit. He has been with us in the executive committee of ISCCM, has been a regular speaker at various platforms, and is now going to talk about as to how do you actually assess a patient from a critical care perspective on the bedside itself, and not just assessment, immediately react to it and give the first, you can call it the first aid or the basic care of that critical care patient in the surgical ICU. So over to you, Dr. Geetesh.
Thank you, Pankaj sir, for the kind introduction. First of all, I would like to thank Dr. Kapoor sir and Dr. Ravi and Dr. Anand for giving me this opportunity. So, Ravi, is the screen visible? Shall I proceed?
Please, yes, it is visible, sir. Please.
Okay. So, I'll be talking about the bedside assessment and basic care of critically ill patients in surgical ICU. So, I'll cover the basic assessment and the basic care of surgical ICU patients. So, as the time permits me, around 20 minutes. So, I'll just touch upon the topics which need to be emphasized during the stay of the patient in surgical ICU. I won't delve into the details of individual aspects much. And I'll be touching upon the quality assessment, which is very important for ICU. And at the end, I'll summarize my talk. So, the role of ICU care in surgical patients is multidimensional. As Dr. Javeri has already pointed out, that critical care is a process and it is not a place. So, the role of ICU comes into management of surgical emergencies like burns, polytraumas, pancreatitis, many more, hemorrhagic shock, hemorrhages, bleeding from any cause, GI bleed, and many more. Then there is role of optimization of the patient. So many patients are brought to ICUs before they are taken up in OT for preoperative optimization, like any acute abdomen patient. And there is a role in optimization of coexisting medical illness. So these patients, before taken up for an emergency or a major surgery, they may need to be optimized in the ICU for a couple of days. Then the most common scenario, that is the post-operative care after a major surgery or operating on a sick patient for close monitoring of vital parameters. The need for mechanical ventilation, obviously we keep them in post-operative ICU, surgical ICUs. And then management of medical conditions and complications as they arise during the post-operative course of recovery. Then the rehabilitation, it starts in the ICU and then it may go a long way till the patient is discharged and even at the home. So that is a long run process, but usually it starts in ICU itself. So as we see, it's a multifaceted approach to the patient. So we need a multidisciplinary care model for these kind of patients. We usually, the primary stakeholders in a surgical ICU, the surgical unit, which have operated on the patient, and then the critical care team. They are primarily like in our tele ICU model, we talk about model. So they are basically hub, and rest of all are on the spokes. So there may be surgical unit. They give their inputs. They do all the job in the OT and post-operative period. Their inputs are very important as in the surgical aspects of the disease. Then the nursing team, which is the core of any ICU, they provide they are the end caregiver to the patient. Then there is rehab team, which includes the physiotherapist, the nutritionist, and in means counselors and psychologists if required for family and patients' psychological support. And then there are medical super specialties which are involved as and when required at the discretion of the critical care team. So all these together form a most multidisciplinary team to deliver the care to the critically ill surgical patient. Now coming on to the assessment and care part of the patients. So the first and foremost would be history taking. So a patient might be coming from emergency, or he may be coming after a RRT from a ward, or he may be coming up from the OT. So a detailed medical and surgery history, surgical history has to be taken. We have to understand the presenting complaints and the diagnosis, the working diagnosis, which is usually available for the surgical patients. Then we have to keep the past medical and surgical history of the patient. We have to go into the medication records. We have to reconcile the medications. It has to be discussed with the concerned specialist if it's required. And some of the medications be limited, depending on the surgery or the anesthesia which has been planned. Then the personal habits and preferences, any addictions, if they are there, they have to be noted, and the therapy perioperative has to be planned according to things. Then any other recent events which have happened, especially as Javeri has talked about, any critical events which have happened in the ward, these have to be noted and taken care of. Then we have to review all the medical records, especially the preoperative investigations and any specialist inputs which have been taken or which are required before proceeding in for a major surgical procedure. Then the operative notes have to be looked into in detail. The amount of blood loss that is taken into the operation theater. Sometimes there are some procedures which are not planned upfront in the OT, but because of some intraoperative findings, some per-op findings, there are some additive procedures which are done in the operation theater. So these things have to be noted. Then per-operative anesthesia records have to be evaluated. The type and duration of anesthesia and the fluid and electrolyte reports per-operatively, the fluid balance, the blood products given, all these things have to be noted. Then there has to be a structured handover from the OT team. This is very important when we are receiving patients in ICU. So the structured handover usually tells you everything about the patient in brief, but the few things which are very important while you are caring in ICU is the post-op analgesia plan. So because this has to be initiated before inducing a patient. So the plan of analgesia is usually made by the anesthesia team, and we in ICU just take it forward next hours or a few days. So it has to be very clearly communicated by the anesthesia team to the ICU team, and any perioperative events, per-operative events which have taken place in the OT, that have to be communicated to the ICU team. These are the things which have to be taken care of, and everything has to be documented very clearly in the records. Now coming on to the assessment of the volume status and the fluid balance, which is very important in these ICU patients. So as we routinely see in ICU, the multipara monitor is there in the ICU. So all the vital parameters are shown on the monitors, which includes heart rate, blood pressure monitoring, the respiratory rate, the temperature. The pulse oximeter shows us the SpO2 charting, the oxygen saturation. So all these are continuously monitored in all the patients. Intake output charting has to be done by the nurses in all the ICU patients. It has to be done hourly. And the drain output, which is unique to surgical patients, and the color and the volume has to be monitored regularly. If there is any change in the color, if there is blood coming out in any of the drain, or any unusual finding from any drain, it has to be communicated to the team immediately. And insensible losses and large volume fluid shifts are possible, especially in GI surgery cases. So these have to be factored in when we are caring of such patients. So then maintaining adequate tissue perfusion. The ultimate goal is to maintain the adequate tissue perfusion. How do we assess tissue perfusion in ICU patients? That is basically by looking at the capillary refill time, and the global perfusion is assessed by looking at the serum lactate levels. And the easiest marker is the urine. So if the patient is adequate, pouring good amount of urine, adequate amount of urine, that is 0.5 to 1 ml per kg per hour, that means the tissue perfusion is adequate. And at the same time, while we are maintaining the tissue perfusion, we have to avoid fluid overload. So that is the balance we want to achieve in surgical patients. Regular monitoring of electrolytes, acid-base balance, and renal functions is very important, especially in patients with large volume fluid shifts and drain output, because this can lead to severe electrolyte imbalances, and at the same time, it can lead to abdominal compartment syndrome, which can lead to dip in urine output and acute kidney injury. So all these things have to be monitored clinically. So what are the clinical signs of hypovolemia? We all know the first and foremost is tachycardia. The patient may be having a thready pulse, narrow pulse pressures. He may be hypotensive, especially orthostatic hypotension, which is the initial sign of hypovolemia. Then poor perfusion, already discussed. Then sunken eyes, dry tongue. These are usually for ward patients or OPD patients who are having these problems for a long time. They are not much relevant in ICU practice. So the common signs of fluid overload include dependent edema. So in bedridden patients, we have to look at the sacral area of the patient, and we may not find the pedal edema unless the edema is means it has progressed to anasarca stage. So we have to look at the bony prominences, the sacral region. So there we can find some edema. Then prominent neck vessels, raised jugular venous pressures, nasal crepitations, and fluid in cavity like ascites and pleural effusions on examination. These are all the signs of fluid overload, or maybe because of third spacing or absolute fluid overload. And point of care ultrasound can be really helpful in means evaluating the fluid status of the patient and targeting the fluid resuscitation and avoiding fluid overload. So we have a separate talk on this. So I'll just move on. So once we have assessed the hemodynamic status of the patient and the fluid status of the patient, apart from the usual vital signs, the fifth, according to WHO, one of the vital signs is pain, and it is very important in post-operative patients because it is a expected outcome after a surgery. So it needs to be assessed by using validated tools. For patients who are coherent and able to communicate, we can use scale like numeric rating scale, which scales the pain at 0 to 10, 10 being the most severe and 0 being no pain. So this has to be the patient has to be made to understand it in his own language, and we need to document it repeatedly and treat it if the patient is experiencing moderate to severe pain. We have to treat it aggressively. Behavioral pain scale and critical care pain observation has been validated for use in mechanically ventilated patients. And most commonly, we use a non-verbal pain scale, which incorporates both behavioral and physiological components and can be used in patients who are not able to communicate. So for ventilated patients, this is the adult non-verbal pain scale, which includes physiological and the physical parameters. They are scaled from 0 to 2. So 5 components, the total score is up to 10. So 7 to 10 is severe pain, which needs to be treated aggressively. So pain control alone may allow patients to be comfortable enough to require no sedation. So usually we have a PAD bundles, which is pain, anxiety, and delirium. How a patient has to be addressed. These 3 things have to be addressed in patient in sequential order. So non-pharmacological interventions are also important. The simple interventions like repositioning or verbal assurance may be comforting to the patient. Pharmacological sedation may be indicated to help relieve discomfort and to improve synchrony in patients who are on mechanical ventilator, and it helps in decreasing the work of breathing also. So validated sedation scales have to be used, and protocols have to be laid down to help nurses deliver the sedation in a titrated manner at the bedside. So the most commonly used scale is the RAS scale for sedation. So the target is to have a patient who is under mild sedation, that is up to from -1 to -2. That is good for all the mechanical ventilated patients, unless he has severe ARDS or some other indications to keep him deeply sedated. So coming on to the choice of drugs. So when we talk about the principle of drug selections, the critical illness brings some unique aspects. So there is, when the patient is in shock, there is decreased hepatic and renal blood flow, so which leads to changes in metabolism. The renal clearance and hepatic clearance are reduced. So we have to adjust the doses accordingly, and we have to repeatedly stop the sedation and check for arousal of the patient and daily. And the use of continuous infusions also alters the pharmacokinetics of the drugs. So that brings into important pharmacokinetic principle of that is context sensitive half-life. So like if we take the example of drug fentanyl, which is commonly used opioid for analgesia. So as we use it in a single dose, the T half is around 30 to 60 minutes. But as we use it in infusions, it increases to multiple times, and it may take 24 to 48 hours to flush it out of the system, and more so if the patient is having hepatorenal dysfunction. So we have to be very mindful when using prolonged infusions of sedative medications. Patient-specific factors such as obesity affects the volume of distribution of lipophilic drugs. So we have to be mindful of the dosing. We don't dose it according to the total. We have to take the adjusted body weight in consideration. Therapeutic hypothermia decreases the volume of distribution and thus leads to changes in plasma concentration. So at the end of the just this topic about analgesia, so multimodal analgesia is usually the preferred post-operative pain relief. So we combine the pharmacological methods with other modalities like neuraxial blockade, peripheral neuraxial blockade, and central neuraxial blockade like epidurals to achieve adequate amount of analgesia with combining the benefits of all the approaches and minimizing the toxic effects of side effects of individual modality. So that is the best, most preferred approach for post-operative pain relief. Now coming on to thromboprophylaxis. So routine evaluation for venous thromboembolism risk and thromboprophylaxis is recommended for all critically ill patients, be it medically ill patients or post-operative patients. So mechanical thromboprophylaxis is considered best when patients have thrombocytopenia and who have a greater risk of bleeding. So this has to be assessed. Post-operative patients, we usually avoid pharmacological anticoagulation at least for 12 to 24 hours after surgery, and hemostasis has to be achieved adequately intraoperatively. So if we see frank blood coming in the drains, these things have to be best practice. What we all commonly do is decide the anticoagulation after a surgical round is done, after the patient's in the morning, like the patient is received from the OT in the afternoon or the evening. So next day morning, the whole team sees the patient, the surgical team, the ICU team, and then we start the anticoagulation, which is preferred with pharmacological therapy for thromboprophylaxis. So for patients with renal insufficiency, unfractionated heparin is preferred, or dalteparin is preferred over enoxaparin, which is the most commonly used and preferred drug for anticoagulation. And we have to monitor the anti-TANA activity in renal failure patients if we are using enoxaparin. For patients with severe liver dysfunction, anticoagulation is challenging, and it has to be, we have to titrate it very carefully, because usually whatever we are monitoring, PTINR and APTD, all these are not very good markers. So it is very challenging to achieve anticoagulation in these patients, but definitely it should be considered. The use of adjunctive compression devices in addition to pharmacological prophylaxis, it did not result in a reduction in DVT as compared to pharmacological prophylaxis alone. So it is not very much recommended. And oral anticoagulants are not recommended prophylaxis in critically ill patients. So we have to use injectables, the subcutaneous low-molecular heparins are. Now coming on to the glycemic control during for ICU patients. So hyperglycemia, as we all know, is associated with increased morbidity and mortality. And hypoglycemia, as a result of treatment of hyperglycemia, it is independently associated with increased risk of death. Coming on to the mechanism of hyperglycemia, which is, we usually call it as stress hyperglycemia. So the reason is basically there is increased production of counter-regulatory hormones, that is catecholamines and glucagon, which lead to enhanced lipolysis and reduced insulin production. So it leads to enhanced gluconeogenesis and glycogenolysis, which leads to hyperglycemia and relative insulin resistance. So all these mechanisms play together to achieve a state of stress hyperglycemia, and it also worsens the glycemic control for a stable diabetic patient. So the hyperglycemia leads to mitochondrial endothelial dysfunction and immune dysregulation, and at the end of the day, it increases the chances of surgical site infection and overall poor outcomes. So for insulin therapy, when it should be initiated, so in critically ill patients, we use only short-acting insulins. The human insulin is preferred agent of for achieving glycemic control. The oral drugs are they are not used, not advisable. So the threshold at which the treatment should be initiated is 180 milligram per deciliter, and the target is 140 to 180. There are a lot of studies which have compared strict control, that is 90 to 120 or 140, with usual control, that is 120 to 180 or 140 to 180. And there are different recommendations from different societies, but this is the most common recommendation which is there to keep the blood sugar targets at 140 to 180 milligram per deciliter. Once patient is clinically stable, he can be shifted to subcutaneous insulin. But normally we use basal insulin, and along with that, when the patient resumes oral intake or enteral intake, we can add a bolus, insulin short-acting bolus pre-meals. So that is how we usually manage glycemic control. And coming on to the nutrition part, every critically ill patient staying for more than 48 hours in the ICU should be considered malnutrition, and medical nutrition therapy should be considered for such patients. Objective nutritional assessment should be done for all the ICU patients. There are various tools available, but none of them is a foolproof tool. So we can use subjective global assessment or other scores, Nutric score or nutritional risk screening. But these are the available choices. So when to initiate? If the oral intake is not possible, early enteral nutrition should be initiated within 48 hours. In case of contraindications to oral or enteral nutrition, parenteral nutrition should be implemented in the first week of ICU stay. To avoid overfeeding, we have to target a 70% hypocaloric feed to the ICU patients. And gastric excess is usually the standard of care, but if it is contraindicated from surgical cause, we can use a jejunal excess, or both are not available. We have to keep the patient on nutrition. Routine monitoring of gastric volume is not recommended in ICU patients. Then, coming on to the dietary requirements, so ideally indirect calorimetry should be used, but it is not commonly available. So, in absence of indirect calorimetry, simple waist-weight equations can be used. So, we usually give a energy requirement of 25 kilocalorie per kg per day and a protein requirement of 1 per kg per day for critically ill patients, and this has to be started from hypocaloric feed. Gradually over first 3 to 5 days, it can be built to the actual energy requirement of the patient. So there are some contraindications to enteral nutrition. One is decompensated shock or severe life-threatening homeostatic abnormalities like hypoxemia, hypercapnia, or metabolic acidosis, active upper GI bleed, bowel ischemia, high output fistulas, then compartment syndrome, and gastric residual volume. If patient is not able to tolerate the feed, the GRV is more than 500 ml every 6 RD, then that is these are contraindications for enteral nutrition, and we have to switch the patient to parenteral nutrition. There are some special considerations like obesity, where we have to use the adjusted body weight for calculations of protein and energy requirements. In polytrauma and burns patient, we supplement enteral glutamine for first week or so. And then if we are giving parenteral nutrition, then we have to pay a special attention to provision of micronutrients, which are usually there in the three-compartment bag, ready-to-mix bags, what we usually get in. They have to be there in the formulation what we are using. Then parenteral nutrition should be considered when enteral nutrition is not feasible or it is adequate. So we can give a complete parenteral nutrition or until the adequate enteral nutrition is established. So we can bridge it and wean the parenteral nutrition or complete enteral nutrition. It's the feeds. Coming on to the one, probably the most important care aspect, that is the infection control measures. So hand hygiene is the most important aspect. Then we all know about barrier nursing. As indicated in immunocompromised patients, we see it in practice transplant recipient patients. Then there are standard care bundles for ventilator-associated pneumonia, the central line-associated gut stream infections, the catheter-associated UTI, and surgical site infections. So all these four are the most important hospital-acquired infections, which are preventable to a great extent. So all the care bundles have to be practiced to prevent these infections. And last and one of the most important topics, that is antimicrobial stewardship. So we have to have a judicious use of antibiotics. Mostly we see that in surgical patients, the antibiotics are given preoperatively, postoperatively, even after the discharge, with no clear evidence of infection. So we have to de-escalate the antibiotics as per the institutional protocols, but these things have to be kept in mind. So we all are familiar with these stages, the moments of hand hygiene and the steps of hand washing when we are doing any surgical procedure. This is of paramount importance. In prevention of SSIs, so as it is a surgical ICU discussion, so I thought that I'll just highlight the SSI. Razors for hair removal and use clippers instead. That helps in reduction of SSI rate. Using chlorhexidine gluconate and alcohol-based skin prep instead of povidone iodine. Maintaining normothermia with active warming. Perioperative glycemic control with target of RBS less than 180 milligram per deciliter, and appropriate timing and choice of prophylactic antibiotic. When the cases are long, the intraoperative period is long, the antibiotic dose may need to be repeated. So that has to means the anesthetist should be made aware of these things, especially in long duration. WAP bundles, we all are we are practicing it. So these are, I'm not going into details. The WAP bundle and the COTI bundles and the CLAPSI bundles. So basically, all these bundles, there are a group of interventions which need to be practiced together and all the times to prevent infections in at these sites. So this is usual care which has to be practiced in all ICU patients. Now coming on to the quality assessment of ICU care. So there are a lot of indicators which are classified according to the focus of evaluation. So there are structure related and outcome related indicators. So, this is example of few indicators what we commonly use to assess the quality of ICU care. Mortality related indicators, morbidity indicators like accidental extubation, reintubation, nosocomial infections. Then safety indicators such as compliance to hand hygiene, blood component transfusion protocol compliance, falls in ICU, sedation protocol compliance. So all these are for safety of the patient. These are compliance indicators. Then safety of ICU personnel, very important. Number of needle stick injuries, it's an example of that. And resource utilization and customer satisfaction level, which are more of administrative and managerial indicators. So we have to be actively involved in quality improvement process in our ICUs. So as a team, as all the stakeholders should be involved in that. And this is the process. We have to plan, we have to identify our problems, what are the areas of concern for our ICU care. Then we have to test potential solution and test them. Then we have to study the results and then finally act and have a team meeting, decide on the action plan and implement the best solution. This process has to be regularly instituted in all the departments, and we need to hold multi-speciality meetings and discuss the issues and form a implementation plan for the ICU. Now, I would just like to summarize my talk. So the purpose of general ICU care is to provide a safe and comfortable environment to the patient while the primary disease is recovering. Pain assessment and assessment of anxiety and delirium is important for all the ventilated and ICU patients. Adequate analgesia and sedation should be maintained depending on the disease status and patient requirement. DVT prophylaxis should be considered in all the patients. Target blood sugar level is 140 to 180 milligram for most of the patients in ICU. Infection control measures should be followed stringently during invasive procedure and prevent nosocomial infections. Chest physiotherapy procedures may be required to facilitate removal of secretions and prevent basal atelectasis, especially in thoracoabdominal surgery patients. Early enteral nutrition is preferred. Collection and interpretation of ICU data is important to identify gaps in delivery of patient care and ensure continuous improvement in quality of care. Regular trainings and team activities are important to keep everyone motivated and maintain a pleasant environment in ICU. Thank you.
Thank you, Dr. Geetesh. A very comprehensive talk covering almost all aspects, and kudos to you for doing this in such a short 21 minutes time. Ravi and Anand, are there any questions coming in? Do we have any questions here?
No, sir. I just checked the Demanshi. There are no questions as such so far.
Okay, then I
Yeah,
think then we
there are
should
no
proceed with the other
Yeah,
talks.
we can.
I
Yeah,
hand
yeah.
it over back to you.
Yeah, but I would request the faculty. I would request the faculty to generate questions for on behalf of students, whatever you think are common issues, common problems. So please generate a discussion.
Yeah, Pankaj, please.
So Geetesh, you have been practicing almost now 10, 12 years, I've seen, and
Right,
you
sir.
worked in various places, and you've also worked extensively in surgical units. So what you think makes a surgical care or surgical acute care different from the routine medical ICUs that we handle? And how you think we should, not just this, we should make our students and the surgeons, upcoming surgeons, more sensitive? What are the issues which they should be looking at when they're seeing patients who are acutely sick in surgical ICUs?
Most commonly, there are lines for various events in ICUs, like first 48, 72 hours. Sepsis is not very common in post-operative, mostly inflammatory state. So many a times we are using the antibiotics. Sepsis is it's everywhere. We are discussing any critical illness. Sepsis is the first thing. So we end up overusing antibiotics in these patients who are actually in the SIRS phase of the disease. So, and the other thing is what we commonly miss is these are thrombotic complications, perioperative MI, DVT, pulmonary embolisms. So, as most of the patients they have comorbid illness, coronary artery disease, or and all the patients are at risk of pulmonary embolism. So these patients are not receiving platelets, anticoagulants, what they were actually receiving before coming up for the surgery. So these are very common scenarios when the patient he gets critical in the phase. These things have to be kept in mind, and bedside ultrasound is actually used in diagnosing these things, a perioperative events like hemodynamic instability. Bedside ultrasound can differentiate between all these etiologies. I think these are a few important issues. Sepsis is overrated in surgical ICUs, I think, especially in first few days.
Yeah, I think I fully agree with you. Post-operative, it's not always the sepsis that kills. I think there are other more bigger killers. As you said, pulmonary embolism happening, a lot of hemorrhages there. So we need to be very sensitive about those issues. Dr. Ravi Singh, sir, you have any comments or questions?
Yes, sir. One more thing I would like to add, that whenever we read data about related to the surgical outcomes and surgical problems in our literature, it is always like more and more data coming from the Western world, and it is not the same story at our place. We have a little less height and little less built up patients. we have a little less physical capacity wise avid patients, and they are not very well versed. They're not very well off with the physical capacity part. So basically, the rehab care is the one missing link most of the time that we find in post-operative critically ill surgical patients. I think there's a lot of work need to be done in that particular area. It is not sepsis always that kills, but the poor general health or poor physical condition is the main culprit agent that comes up most of the time. I think Dr. Geetesh was making the same point.
Yeah, I think one small point I would like to make here. Not all post-surgical or elective complications. We have a lot of trauma happening in our country. And I think good trauma acute care is extremely needed. We need our own courses happening in medical schools. Not ATLS is very good, but not everyone has access to ATLS. So we should have courses like the Indian versions of trauma care. I think that is very, very important, which every medical graduate should learn, not just the intensivist or the emergency guys. I think that is important. I think with this, I would now like to continue. We'll now continue with the further proceedings. Handing it over back to you, Ravi. Thank you.
Thank you, Dr. Anand, sir. Thank you, Dr. Yash Javeri, sir. Thank you, Dr. Geetesh Mangal, sir, for the very interesting talks over here. I'm really sorry for the technical glitches that happened in the initial part of this talks. Sir ended his words with trauma. And now I have our next chairperson, Dr. R.K. Singh, sir, from SGPGI Emergency Medicine Department, head of the Department of Emergency Medicine. I think there's no other person who understands better the trauma and acute care than an emergency physician head. So over to you, sir, for to chair the next two topics. I would like to welcome you on. Thank you, sir. Please take it over.
Thank you. Thank you, Ravi. It's nice to be associated again with Professor V.K. Kapoor, and thanks him for the kind invite. The initiative of JST is well appreciated. I believe the audience in this session is enjoying the interactions and the type of topics that are relevant for critical with surgical background patients. Now, I would invite the next topic, keeping the constraints of the time, Dr. Ashish Jain, who had extensive work experience in many of the world-renowned medical centers, has more than 14 years experience in clinical and critical care medicine, teaching and training. He's a certified instructor to many of the skilled courses. And he's also in the executive committee of the ICCM Jaipur branch. I'm sure he is aware of the entire critical care people in the Jaipur scenario. And welcome him for the topic that he has, I think it's on ABG interpretations and the basic arrhythmias. So Dr. Ashish, please go ahead.
Evening to everyone. Mr. Dr. Ashish Jain, I'm Director and Professor Department of Critical Care Medicine at Mangal Hospital, Jaipur. Today, our topic of discussion is interpretation of data, ABG and basic arrhythmias. And in today's talk, I'm going to provide one approach for the interpretation of ABG and cases. First, coming to the anatomy of a blood gas report, you can see there are some measured values like pH, PCO2 and CO2, and calculated values in the form of bicarbonate with the help of Anderson equation. In normal an ABG machine, it measures pH, PCO2 and PO2, but it can also measure like electrolytes, hematocrit, co-oximetries, methyl hemoglobin, fetal hemoglobin, and oxygen saturation. Bicarbonate is always a calculated value with Anderson equation, but there are certain other kind of values which is written over the ABG report, that is bicarb standard and base axis. And please do not use them for the calculation or the reading of an ABG because they could be misleading. First thing is to identify the level of oxygenation, for which we need to see the PaO2. And PaO2 depends upon the age, FiO2 and atmospheric pressure. The normal level of PaO2 is from 60 to 100 mm of Hg. And we need to calculate the alveolar arterial oxygen gradient, because of which we can utilize to differentiate the various causes of hypoxemia in any patient. Now, for the calculation purposes, we have to have some normal values of different parameters like pH. The normal value is 7.40. PCO2 is at 40 and PO2 is 80, and bicarbonate we think it is around 24 for the calculation purposes. So how to calculate or interpret an ABG? The first step is check the validity of ABG. We need to calculate the H positive ion concentration with the help of Henderson equation. That is H positive ion equals to 24 into PCO2 on bicarbonate. These two values are given in the ABG machine. And then we can use the algorithm table and the logbook. With the help of this, we can identify the level of H positive ion with the rule of 80. Suppose our pH is 7.20. So we will deduct this 20, the 2 digits after the decimal, from 80 concentration would be. If calculated and measured, both values are similar or approximating to each other, it indicates our ABG is valid and we can interpret the ABG. Now the next step is to know whether patient is having acidemia or alkalemia. It depends upon the pH. If pH is less than 135, it is acidemic. If more than 7.45, it is alkaline. Second step is whether this problem related to respiratory problem or it is a metabolic problem, for which we need to see two parameters. One is bicarb level for the metabolic derangements and carbon dioxide or PCO2 level for the respiratory problems. For the respiratory problems, if we see if primary changes are in the carbon dioxide, if carbon dioxide is high, it is respiratory acidosis. If it is low, it is respiratory alkalosis. Similarly, if bicarbonate levels are low, it is metabolic acidosis, or if bicarbonate levels are high, it is metabolic alkalosis. Coming to the step 3, once we have identified that the primary problem is respiratory disturbance, we need to see whether it's acute or chronic. Acute means the problem starts for a few hours or few days, but chronic problem like COPD, it is there for weeks or months. After that, we should see whether kidneys have started compensation or not. For the compensation, we need to calculate and we need to see the expected bicarbonate level. For every change of 10 in PCO2 level, whether it is high or it is low, the renal compensation for bicarbonate will be like 1, 4 and 2, 5. In acute cases, when the time is less, kidneys has not yet started compensation completely, so the change in the bicarbonate values are low. While in chronic conditions, the kidneys has successfully done the compensation and the bicarbonate levels would be a little bit higher. Step 5, if the disturbance is metabolic, then we need to see it is acidotic or alkalotic depending upon the bicarbonate value. If it is metabolic acidosis, then we need to see what is the level of respiratory compensation. So here we will calculate the expected carbon dioxide level. And for the alkalosis, we will calculate the expected carbon dioxide level with the formula. If the actual carbon dioxide is more than the expected carbon dioxide, then there is hidden respiratory acidosis. Why? Because actual carbon dioxide is higher than the expected carbon dioxide. Similarly, if actual carbon dioxide is low than the expected, that means patient is having respiratory alkalosis. In step 6, Once we have identified the patient is having a metabolic acidosis and there is a respiratory compensation, we need to know which kind of metabolic acidosis it is. Whether it is high NANCAP metabolic acidosis or normal cap acidosis, for which we need to calculate the NANCAP. The formula for calculation is sodium minus chloride plus bicarb. The normal level of NANCAP is 12, or we can say 12 to 14. If it is more than 12, then it is high NANCAP metabolic acidosis. If it is less than 12, it is non-GAP metabolic acidosis. Here you can see there are few reasons for the high non-GAP metabolic acidosis. This metabolic acidosis levels are also, this non-GAP level is also dependent upon the level of albumin in the blood. Then the step 7 depends upon the delta gap. Delta gap means the gap from a NANCAP minus 12, that is called the delta NANCAP, and delta bicarb, that is 24 minus bicarbonate level. So if delta, generally in a normal patient, delta NANCAP should be equal to delta bicarbonate gap. If delta NANCAP is high, that means metabolic acidosis is also associated with metabolic alkalosis. And if delta NANCAP is less than delta bicarb, it means metabolic acidosis is associated with non-NANCAP metabolic acidosis. So two kinds of metabolic acidosis are present: high NANCAP metabolic acidosis and normal NANCAP metabolic acidosis. These are the few causes of metabolic alkalosis, and to differentiate between these two types, we need to look for the urinary chloride. If urinary chloride is less than 20, it is chloride responsive metabolic alkalosis, and few causes are vomiting, NG suction, cystic fibrosis, or remote diuretic use. While if chloride level is high, then it could be current diuretic use, potassium supplementation, depletion, exogenous alkali, Bartter syndrome, or hyperaldosteronism. Now coming to a few cases. Case 1 is a 30-year-old female who presented with sudden onset of dyspnea. So what should we do first? We should check the validity. If you see here, the pH is 7.52. So if we calculate by the rule of 80 minus 52, expected PCO by H positive ion level will be 28. Similarly, with the equation 24 into PCO2 upon bicarb, the H positive ion concentration is coming around 30. That means both of these values are approximating each other. We can say the ABG is valid. Case 2, a 60-year-old female, a male smoker with progressive respiratory stress and hypersomnolence. So pH is less than 7.35, it is acidemia. PCO2 is high, it is respiratory acidemia. Acute or chronic, with the calculation we came to know it is chronic respiratory acidosis. And for the compensation is almost normal compensation, full compensation, so it is pure respiratory acidosis and associated with hypoxemia. The NANCAP is normal, that means it is this hypoxemia is because of hypoventilation. Coming to case 3, it is a case of 18-year-old male asthmatic, 3 days history of cough, dyspnea, and orthopnea, but he is not responding to use of bronchodilator. The ABG should be pH, which is 7.23, that means acidemia. PCO2 is high, respiratory acidemia. Acute or chronic, with the calculation, we came to know it is acute respiratory acidosis. So, with that, we need to calculate the expected bicarbonate levels. And if we see the bicarbonate level expected are 26, while actual bicarbonate are 24. That indicates that there are hidden metabolic acidosis. So we calculate the NANCAP, and NANCAP is coming 16. That means this patient is having acute respiratory acidosis along with high NANCAP metabolic acidosis with hypoxemia, with very high alveolar arterial oxygen gradient, indicating there is severe hypoxemia. Coming to case 4, a 20-year-old diabetic with respiratory distress, fatigue and loss of appetite with a pH of 7.23, that means it is acidemia, bicarb are low, PCO2 is also low, it indicates metabolic acidemia. For the metabolic acidemia, the expected carbon dioxide level would be around 27 to 31, and we have 34, so patient is having metabolic acidosis along with respiratory acidosis. Gap, if we calculate, it is high anion gap metabolic acidosis, and if we check the delta anion gap and delta bicarb, it indicates that the delta bicarb are higher than the delta anion gap, indicating it is associated with non-gap metabolic acidosis also. Now coming to interpretation of the basic arrhythmias. So what is ECG? ECG is a representation of electrical events of the cardiac cycle. And we know that generally the electrical activity in a heart originates from the SA node, and which has an intrinsic rate of from 60 to 18, followed by AV node, which has a backup rate of 40 to 60, and a ventricular cells, which has an intrinsic rate of 20 to 45. This is a normal ECG waveform where we have P wave, which represent the atrial depolarization, that means contraction, QRS complex, which represent ventricular depolarization and atrial relaxation, and T wave, which represent ventricular relaxation or the resting phase. If we take a 12-lead ECG, we have chest leads as well as the limb leads. So these leads indicates different portion of the heart. Lead 1 and AVL shows the lateral portion of the heart, while 2, 3 and AVF indicates about the inferior portion of the heart. V1 and V2 indicates towards the septal pathology, V3, V4 anterior, and V4, V5 and V6 indicates towards the lateral wall pathology. For interpretation of ECG rhythm, there is an algorithm, again a 5-step approach. First, we need to see the heart rate, rhythm, E wave, PR interval, and then QRS complex. For the calculation of heart rate, we need to calculate the large square between two R waves, and then divide 300 by the RR interval, and you will get the rate. We can also calculate the number of small squares between two R waves, and we can divide 1500 by this number of small square to calculate the rate. For the rhythm, we need to see the RR intervals. If RR intervals are coming at a regular distance, that means rhythm is regular, and otherwise it is irregular. So here you can see the RR interval are coming at is same, the QRS complex are coming at regular intervals, which is regular rhythm. And here, if you see, this RR interval is less, this RR interval is high, so it is an irregular rhythm. Then we need to see the P wave. So we have to have 5 questions in our mind: whether this P wave is present or absent. If it is present, are these P waves are occurring regularly, or there is some delay, or there is some dropped P waves, or is there one P wave present for each and every QRS complex? And what is the shape of this P wave? Then we need to see the PR interval, which starts from the beginning of P wave and ends at the start of R wave. The normal duration is 0.12 second to 0.20 second, that means 3 to 5 small squares. And we need to see whether this PR interval is normal, high or low. Then in step 5, we need to see the QRS complex. The normal duration of QRS complex is 0.06 second to 0.01 seconds. That means 1.5 square to 3 small boxes. And again, we need to see here, this QRS complex is less or smaller, or this QRS complexes are bigger on the ECG strips. And in the last, we can see the P waves also. Very commonly, we can see these kind of ECG patterns, and it is primarily because of the patient movement or loose or defective electrolyte attachment to the chest wall. So we should discard this kind of ECG. The normal heart rate or the normal sinus rate is 60 to 100. Sinus bradycardia is called when the heart rate is less than 60, tachycardia when the heart rate is more than 80, and there is cardiac pause or the sinus arrest also seen. So when we call it normal sinus rhythm means that each and every QRS complex is coming at a regular interval. If normal P wave is present, followed by a QRS complex, PR interval is normal, QRS interval is normal, P wave is there, and RR interval is also normal. Sinus bradycardia indicates the rate is less than 60, but the rhythm is regular, P wave is regular, PR interval is regular, and QRS complexes are also normal. While sinus tachycardia indicates that the rate is high, more than 100, but the morphology of QRS complex and different intervals are normal. Sinus arrhythmia, we say sinus arrhythmia is a normal variation in the beating heart. It generally seen during the inspiration and expiration. Here, the QRS complex is normal, but the rhythm is variable. That means the RR interval is variable. Then there are certain atrial arrhythmias. What are they? Atrial flutter, atrial fibrillation, supraventricular tachycardias, and premature atrial complexes. So how to identify atrial flutter? Atrial flutter means we can have a number of more than 2 or 3 P waves between each QRS complex. So we can see here, this is a sawtooth appearance, and these appearances are here because of the multiple P waves. P wave, so there are 3 P waves. So the PP interval, the rate of atrial contraction is around 300, but the rate of ventricle contraction is around 72. It is regular or maybe irregular. PR interval we cannot calculate, but QRS interval is normal. In atrial fibrillation, we need to know that it is irregular rhythm. You can see on this strip, there is no P wave. We cannot identify whether there is any P wave or not. The PR interval is variable. The QRS complex is normal. QR duration is normal, but there is no PR interval. So this is called atrial fibrillation. It is very commonly present in elderly age group of patient. Then the supraventricular tachycardia. Supraventricular tachycardia, the atrial rates and the ventricular rates are high. It's around 200 or 150. P wave are generally indistinguishable. We cannot identify them. PR interval we cannot identify, but QRS complex and QR duration is normal. Then coming to the ventricular arrhythmias. When these ventricular arrhythmias appears, when the SA node and AV node and the junctions fail to generate the impulse, then the ventricles will assume the role of pacing the heart. As there is no SA wave, SA nodal impulses, so there is no P wave, and there is no atrial activity or depolarization. Only there is ventricular depolarization activity. The QRS complex, because it is originating from the ventricle, is wide, or we can say it is more than 0.12 second or 3 small square, or we can say it is bizarre in appearance. So there are 8 kind of ventricular rhythm, and these ventricular rhythms are lethal. First is premature ventricular contraction or PVCs. Here you can find in a normal ECG pattern some broad complex appears. These broad complexes does not have any P wave. The QRS duration is big, more than 0.12 seconds. And when these complexes appears after each and every beat, it is called ventricular bigeny. When this PVC occurs every hour after every third beat, it is called ventricular trigeny. Sometimes more than 2 PVCs are coming together. These are called couplets. If 3 or more than 3 premature ventricular contraction beats are there, it is called ventricular tachycardia. Then comes the idioventricular rhythm. Idioventricular rhythm is also termed as a ventricular escape rhythm. Here the heart is failing. that heart is not generating good amount of cardiac output. The heart rate is 15, 20 to 40, and we need to act fast to salvage these kind of patient. Similarly, there is accelerated idioventricular rhythm where the QRS complex is big, T waves are absent, but the rate is 40 to 100. Cardiac output is compromised. You need to work very fast. Then comes the agonal rhythms. Agonal rhythms are when the idioventricular rhythm is even less than 20. So you will see few beats throughout the ECG recordings, and generally it is seen after failed resuscitation efforts. Ventricular tachycardia, here you will see the run of broad complexes, QRS complexes on the ECG. There is no P wave, there is no PR interval. QRS complex is big, bizarre, QR interval is high, more than 0.12 seconds, and generally patient does not have pulse. It may be present with pulse, but these tachycardias very early converted to ventricular fibrillation. Then comes the ventricular fibrillation. It could be of two types, coarse and fine, where you will see just a bizarre, different shape of white complexes, no PR interval, no Rs, there is no P wave, you cannot identify any morphology of QRS complexes. Patients are generally in cardiac arrest, there is no pulse. And we need to act fast, patient need immediate defibrillation. Then comes the ventricular standstill or asystole. There is no electrical activity. You can say flatline ECG. Here is a special situation where the electricity in the heart is working. That means there is electrical activity, but there is no pumping. The mechanics of the heart is not there. So practically the patient is clinically dead, but there is some kind of rhythm is seen on the monitor, and we need to continue our CPR in this kind of situation. In the last, we should talk about the blocks. Blocks depend upon the PR interval. It is of three types, type 1, 2 and 3. The first AV block is characterized by a long PR interval more than 0.20 seconds. Second degree heart block is divided into two types, Movitz 1 and Movitz 2. In Movitz 1, there is gradual increase in the PR interval followed by drop beat, while in Movitz type 2, there is a fixed high prolonged PR interval followed by missed beat. In third degree or complete heart block, there is complete dissociation of atrial contraction as well as the ventricular contraction. So here we end our presentation. Due to the time constraints, I have to rush, and I hope you will enjoy this presentation. Thank you very much.
Thank you, Dr. Ashish. I know it is a vast topic to be squeezed into one presentation. There are ideally two topics separately, and therefore we could feel the rush that was there in the presentation to finish it in time. But remember, ABG and ECG are both practice-oriented things, okay? The more you practice, the more you become well-versed. And I think you have done justice by speaking on most of the things in the span of time that was given. Thank you, Dr. Ashish.
Singh, sir? Yeah, can you hear me?
Yeah, I can.
Yeah, so we have two questions related to the previous sessions. So we'll just take them up very crisply. And then, so one question that popped up is, especially which surgeries have massive fluid shifts? Yeah, that is one question. And another question is, what special precautions should we take in post-surgery apart from regular ICU care? So I think the second one we have discussed vastly in the Dr. Geetesh Mangal's talk. What special precautions do we need to take apart from regular ICU care? So do you need to shed some more light on these a couple of points? maybe. Will you?
I think this question is addressed to the previous speakers
Yeah. Yes, sir.
or to
Dr.
anybody in the
Geetesh,
audience.
Geetesh, sir, I think he has left. Yeah, but the crux of the story, like I can discuss it over here. The crux of the story, post-surgery patient, apart from regular ICU care, we need to focus on early enhanced recovery care. We have a separate topic tomorrow coming on the same topic. As I elaborated earlier, that Indian patients are different from the Western world patients. So surgical outcomes are also going to be different from the Western world patients. We have more and more like we have a less physical capacity, less muscular mass built up patients in our country. So we need to focus more on rehabilitation and nutrition care in apart from other routine care that we provide to the patients. And massive fluid shift surgeries are basically the surgeries that require the direct openings of peritoneal cavity, maybe, or maybe thoracic cavity. Large surface area need to be exposed in massive fluid shifts, if you ask it in other ways, conceptually. So, since over to you, you can go ahead and introduce our next speaker. Let me share the screen for Dr. Shubhendu.
Please share the slide. Okay,
Yeah.
so the second topic is the in thing for the ICU and the critical care. And I believe this will just touch the surface of what we do in the intensive care, in the emergency in terms of sonography. And I'm sure the speaker is going to deliberate on Dr. Shubhendu Bajpai, and he's a practicing critical care medicine for last 10 years. He's member of the Institutional Antimicrobial Stewardship Program, has many research publications, currently working as a post-cardiac surgical ICU. And his core interest areas are in cardiogenic shock, RV failures, ECMO, septic shock, and POCUS. So here we have a speaker interested in POCUS, and I believe the presentation is going to be of massive interest to the surgeons who want to go into the realm of POCUS on bedside for critically ill surgical patients. So please go ahead, Dr. Shubhendu.
Thank you very much, sir, for the kind introduction. And thank you, Team JST, for giving me this opportunity to share my views on point of care ultrasound in the ICU.
Shubhendu, please share your screen also.
Yes, sir.
Yeah, please go ahead.
I hope I am audible and the presentation is visible to all.
Yeah. Please make it present.
Yeah.
Okay. Slide. Good.
So,
go ahead.
At the outset, this is my disclaimer. I am not a radiologist or a cardiologist. And because of the brevity of time that we have, we'll just, like Professor Singh said, we'll touch those topics. We'll just go through we'll just touch them, because the entire point of care ultrasound is a 2 days workshop, and I have to finish it in 20 minutes. So we'll give a brief introduction to the POCUS. We'll go through the USD guided cannulation procedures, FAST, how to analyze DVT, cardiac ultrasound, lung ultrasound, rush, and then we will conclude this. So why do we need ultrasound in the first place? To enrich and enhance our patient evaluation. From long times, history and physical examination has been there. Then came lab investigation, and then came radiological imaging to analyze and to approach the patient, to evaluate the patient. So the next question is that which imaging is better in the ICU? If we take into account all these things, portability, safety, easy reproducibility, dynamic imaging, the cost involved, and the image quality. I think ultrasound is the modality of imaging which it stands the test of time in all those parameters. It is portable, it is safe, no risk of radiation involved. It is reproducible. You may do it as many times as you want. It is obviously the cost of the machine is expensive, but using it repeatedly is not that expensive, and the image quality definitely depends on the operator. If the operator is experienced, the image quality is good. What is the utility of POCUS? Why do we need point of care ultrasound in the ICU? There is some diagnostic use to it, there is some therapeutic use to it, and we can use ultrasound in the ICU for repeated assessment. Diagnostic use is like lung ultrasound can be used to diagnose pleural effusion, pneumothorax consolidation in a patient short of breath. A patient who has come to us in a clinical picture of cardiogenic shock, we would like to confirm it with the ultrasound and try to find out whether it is RV failing, whether it is LV failing, or whether it is fluid collection around the heart. A patient with distended belly, yeah, clinically we are suspecting it as ascites. We would like to confirm it with the ultrasound. Patient with a swollen limb, yes, we would like to put a linear probe on the femorals and try to demonstrate DVT there, saving a lot of time and making the diagnosis quick. Therapeutic uses: ultrasound guided vascular cannulations, the in thing, ultrasound guided paracentesis, abdominal paracentesis, thoracentesis, and percutaneous tracheostomies as well. And repeated assessment, so volume assessment, like our previous speaker said, urinary bladder assessments. Sometimes, in the ICU, the urine output is not coming, the urine output is decreasing, or the urine output abruptly stops. And despite of doing everything, despite of fluids, despite of diuretics, the urine is not coming. And the moment you flush the catheter, the urine starts pouring. So you can confirm all these things with the ultrasound there. How does the USG probe work? And I have a very small presentation on this.
Dr. Shubhendu, it's not audible. If you can speak something about it.
The video is not audible, is it?
No, it's not audible.
Okay, no issues. So the whole idea of showing this video is that AC current is applied to the probe. There are piezoelectric crystals in the probe. The piezoelectric crystals generate ultrasound waves. The ultrasound waves goes into the tissues. They strike the structures in the tissue. Then they reflect back, refract back, and some of them get attenuated in the tissue. So those ultrasound signals that come back to the piezoelectric crystal on the probe are then converted into the images on the screen. So that is how our probe works. The next thing of concern is echogenicity. Yeah, so we say gray, white, black on an ultrasound. What sense does it make? There are certain hyperechoic tissues like diaphragm, tendons, and bones, which reflect back a lot of ultrasound waves. There are certain hypoechoic tissues, like most of the solid organs or thick fluid in the body, which create a grayish kind of appearance on the ultrasound screen. And then there is fluid, blood, and urine, which do not reflect back any ultrasound waves and hence appear black on the screen. Coming to the basic knobology, what buttons on the ultrasound machine are of prime importance for us as a beginner? The switch on, switch off button, the depth adjustment switch, the gain adjustment switch, and the switch with which we can change the transducers. So the higher the frequency of the probe, the better the resolution. The linear probe which we have has higher frequency, and hence we are able to get better resolution of the superficial structure. So better the resolution and lesser the depth. The lower the frequency of the probe, the lesser the resolution and more the depth, like the curvilinear probe. The curvilinear probe gives us good depth analysis, but with a lesser resolution. What is gain? Gain is just a fancy term for, brightening the screen or darkening the screen. You increase the gain, the screen brightens. You decrease the gain, the screen darkens. A brief slide on transducers. Linear transducer with a frequency of 5 to 13 Hertz. You see on the screen, this is the probe with the maximum frequency. The maximum frequency, the best resolution, and the most superficial structures. Curvilinear probe with a frequency of 3 to 7 megahertz. Phased array probe with the cardiac probe with a frequency of 1 to 5 Hertz. Now coming to USG guided vascular access. The more you do, the better you get. Why do we want to do it on the first place? Why isn't blind vascular access cannulation good enough? So what are the advantages of using USG? You identify the accurate location of the area of interest. You identify anatomical variations. You identify if there are any venous or arterial thrombus within the vessels, and you avoid damage to the nearby structures. What does evidence have to say in favor of USG guided central venous catheter insertion? A randomized trial of 900 patients published in Critical Care in 2006. The slide says it all. Carotid punctures. The first figure is USG guided. The second figure is blind procedure. It is self-explanatory. Now coming to the approaches, longitudinal approach. See, here we are looking at the right IJV of a patient. Yeah, I want to use the marker, the pointer. So this is how my IJV is going, right? This is how my IJV is going here, the right IJV, and along with it, I have placed my USG probe just on top of it, parallel to it. This is the longitudinal approach. This is how I place my probe and see from the width of the probe, just at the middle of the width of the probe, I want to introduce my needle, and this is how the needle will appear. Yeah. So I have made the entire jugular vein visible here on the screen, and then my needle is approaching here from the middle of the probe. Coming to the transverse approach. So this is how my internal jugular vein is going, and this is how perpendicularly I have placed my linear probe. And I'll introduce my needle from here, and this is how it will look on the USG screen. This is my needle here. This is the internal jugular vein. Yeah, coming back to anatomy, this is the internal jugular vein, this is the artery here, this is the vein, and here is the needle. Now coming on to, so this is the principle, transverse approach, longitudinal approach. This is the principle. You can use it for arteries, you can use it for vein, you can use it for jugular, you can use it for femoral, wherever you want, however you want. Now coming to use of USG in trauma setting. I have a brief scenario to share. 24-year-old male present to the ER after a motor vehicular accident, conscious with a heart rate of 130, blood pressure of 80/50, looking pale. Resuscitation started after securing cannulas, investigation sent, and monitoring is attached. The question that each and every physician has in mind is that where is he bleeding from? We need an answer. So just call in the ultrasound. We will perform a focused assessment with sonography in trauma, that is popularly known as FAST. Where do we want to place the probes? In the right upper quadrant, in the left upper quadrant, in the cardiac region, and in the suprapubic region. In cases of extended FAST, we might also have a look at the bilateral pleuras. So, if there is a motor vehicular accident with some intraperitoneal bleed and you place a curvilinear probe, mind you, we will be placing a curvilinear probe because we want to have a look at the in-depth structures. So most of the things can be visible with a curvilinear probe when we are performing a FAST. So you put a curvilinear probe in the right upper quadrant, and if there is free fluid, this is how it is going to appear. Yeah, the slide is self-explanatory. You have liver here, you have diaphragm here, you have lung here, you have kidney here, and this Morrison pouch between the liver and the kidney has having free fluid here, which is clearly visible on the ultrasound. So a patient with hemorrhagic shock, a patient sinking, coming to the ER, and you have a cause. So we will target for source control and resuscitation simultaneously. Similarly, when you place this curvilinear probe on the left upper quadrant, the structures visible to us are lungs, the diaphragm, the spleen, and the kidney. And here we can see that there is collection above spleen and below the diaphragm. That explains. Sometimes when we put the probe subcostally, this is the picture we can get. You see the pericardial sac here and the heart floating inside, massive fluid here. Similarly, when we place the probe suprapubic in the pelvic area, this is the bladder distended and this is free fluid in the pelvis. So all these are giving us one comprehensive answer without wasting time, without shifting a hemodynamically unstable patient to any radiological places, and directly taking calls, taking the decisions about how to address this patient further. Abdominal trauma. This is a slide addressing the utility of the FAST. Abdominal trauma, unstable patient, FAST positive. Shift the patient to the operating room. FAST negative. You might want to resuscitate the patient and maybe do a CT later on. Stable patient, FAST positive. Shift the patient to CT, confirm the diagnosis and take him to the OR if needed. If the FAST is negative, then you stop, then you repeat your fast, and you observe, and depending on the clinical picture, you take the further call. Correct. A 65-year-old female operated case of neck of femur fracture, pardon me, comes to us with right lower limb edema after 1 month of surgery, poorly mobilized after surgery. Yes, edematous limb, post-operative patient, poorly mobilized. What is the first differential on our mind? It is DVT. We want to confirm it. How much time does it take? Here comes the USG machine. You place the linear probe on the femoral area. Say if there is right lower limb, you place the linear probe on the right groin with the pointer of the linear probe medially, and this is the picture you get. Yeah, femoral vein with a clot inside, femoral artery. How do you make a call whether this is thrombus? How do you say this is DVT? So there are certain direct signs. You can see the thrombus within. There is incompressibility. If you want to press the vein, it is not getting pressed. The diameter of the vein has increased. There is no pulse wave Doppler. There is no color flow Doppler. And hence you confirm the diagnosis of DVT in a lady with a clinical history and physical features of DVT within no time. Now coming to the cardiac evaluation in POCUS. So what are the objectives? See, we are not cardiologists. We don't want to, calculate TAPSE, calculate MR, calculate TR and whatnot. We just want to eyeball the heart. We just want to know as to why the patient is going in shock. Is the LV kissing? Are all the ventricles shrunken? Is the IVC shrunken? Is the patient hypovolemic? Is the patient hemorrhagic? Or is the LV dilated extensively? Has the heart failed? Is the patient in cardiogenic shock? Or is the RA-RV dilated? With a clinical background and physical examination of DVT, with a clinical background of pulmonary embolism, is the RA-RV dilated? Is there TR? Or we in a backdrop of some cardiac procedure with a low cardiac output, we want to look for pericardial collections. We want to look at the IVC. So first of all, we would want to know the different basic views of 2D echo, and then based on those views, we will want to know as to how a failing RV looks, of how a failing LV looks, how a pericardial collection looks, and how the IVC looks. So this is the phased array probe or the cardiac probe, which is commonly used with the footprint here, the pointer here, and the body here. These are the common areas from where we analyze the heart. This is the subcostal area beneath the xiphisternum. This is the apical area beneath the nipple in the left fifth intercostal space. This is the parasternal area, the second and third intercostal space. And this is the suprasternal area. So now coming to the views. How do we make the view of a parasternal long axis? So this is our phased array probe with a pointer pointing towards the right shoulder in this fashion. This will cut your heart in this fashion, and this is the image on the echo. LA, LV, mitral valve, aortic valve, LVOT, and RV. This is the kind of image you can create with a parasternal long axis view. Now in the same position here, we will just rotate the probe in such a manner that now the pointer would be pointing towards your left shoulder. And now your probe is cutting the heart in this fashion, showing your RV here and showing your LV here. We will see videos in the coming slides to make the things more clear. Apical four chamber view. At the apex of the heart, with a pointer towards the left shoulder, cutting the heart like this. This is the image that you get. LA, LV, mitral valve, RA, RV, tricuspid valve. Subcostal view, beneath the xiphisternum, like this, beneath the xiphisternum and pointing towards the left shoulder. This is how it cuts, the ultrasound beam cut your heart, and this is the image that we generate. Now, let me show you how a normal study looks. Yeah. A parasternal long axis view. LA, LV, mitral valve, aortic valve, and RV. Parasternal short axis view. LV, RV, good contractility. This is a normal study. Nothing to worry about. Let us go through a clinical vignette. A 55-year-old male, chronic diabetic hypertensive, presented to ER with chest pain and shortness of breath, ECG suggestive of ST elevation, MI in leads, V1 to V4, cardiac markers are positive. All of us know this is MI, but the vitals are heart rate of 120, the pressure of 80/50, saturation of 90%, Bilateral auscultation reveals coarse crepes. The peripheries are cold and very low urine output and catheterization. All things pointed towards cardiogenic shock before we have a ABG to demonstrate metabolic acidosis and increased lactate. In this setting, I want to have a look at the heart. So a failing LB, patient in cardiogenic shock, this is how it is going to look. This is how it is going to look in parasternal long axis view. This is how it is going to look in a parasternal short axis view. Yeah. The clinical vignette I am sharing just for all of us to corroborate it clinically. RARV dilatation. A 65-year-old female operated case. This is the same lady which we took there in DVT, but now she is having a operated case of neck of femur fracture, right lower limb edema after 1 month of surgery, shortness of breath with tachycardia and tachypnea. These are the additional features which she is having now. Poorly mobilized after surgery. Yes. The vitals, heart rate of 130, blood pressure low, saturation of 82% on room air, the respiratory rate is 25 to 30, auscultation is clear, the chest X-ray is normal, our suspicion goes towards pulmonary embolism. We somehow want to confirm it. What will we do? Here is the echo, making a apical 4-chamber view. The RA is dilated, the RV is dilated, and there is some TR. Forget about the TR, we don't need to know the TR, but the RA-RV dilatation in the clinical setting of a pulmonary embolism with a swollen limb. At the same time, I would also want to put a linear probe on the femoral vein and check if there is DVT. Presence of DVT with RA-RV dilatation in itself is self-explanatory for pulmonary embolism. Now, 50-year-old female taken up for TPI ended up with worsening hemodynamics and pale look and cold peripheries, rising lactates, dropping urine output. See, she was taken up for TPI. Something has happened there. Suddenly, the patient has started to deteriorate. The hemodynamics are worsening. The peripheries are cold. The urine output is dropping. I am wondering something has happened in the cath lab. I need to place a probe on the patient. The moment I place a probe, this is the image that generates. I would like to play this short video, which would demonstrate pericardial collection and tamponade in this patient. You see? A lot of fluid around the heart. The heart is flowing inside the fluid. The moment there is diastolic collapse of RA and RV in the setting of pericardial collection, it becomes cardiac tamponade. So from cardiac tamponade, the cardiac tamponade reminds me of the 5 T's of cardiac arrest. T for cardiac thrombosis, MI, T of pulmonary thrombosis, pulmonary embolism, T with pneumothorax, and T with tamponade. So all those 5, the toxin obviously cannot be addressed with ultrasound, but the rest of the 4 T's can be addressed and analyzed with the help of a ultrasound. IVC assessment. So say you are in the ER and a 18-year-old female comes with diarrhea, vomiting, nil per oral since 1 day, tender abdomen, history of food consumption outside 2 days back. Yeah, everything is pointing towards food poisoning maybe. And she is dehydrated and the tongue is dry and she has not passed urine since 1 day and she's tachycardic and all those things. I want to resuscitate this patient. If clinically she is dry, I will resuscitate it. How long? How long will I resuscitate the patient and how am I assessing the improvement of the volume status of this patient? Yes, I can do it with the help of IVC assessment. See, the heart, the IVC, the hepatic vein opening in the IVC. This is a normal IVC of less than 2 centimeters and there is a lot of variation with breathing. This is a dilated taut IVC with no variation with respiration. And this is the difference. How do we see the IVC? We just place the probe subcostally and we just turn the USG probe in such a manner that the pointer now comes upwards. Now coming to lung ultrasound. We have discussed so far fast, we have discussed DVT and we have discussed cardiac ultrasound. Now coming to lung ultrasound, which is the second last topic of the talk. Why do we need lung ultrasound? Patient with shortness of breath, patient with desaturation, patient with tachypnea. We want to find out as to why the patient is in distress. A patient is intubated and the patient is desaturating. I can rule out endobronchial intubation with the help of lung ultrasound. The patient comes with failure, LBF. I can diagnose as to a patient with a known case of COPD and low ejection fraction comes to me, he's in pulmonary edema. Yeah, on auscultation there are co-script, but I want to confirm this diagnosis with the help of ultrasound. I can do that. Pleural effusions, yeah, cirrhosis, cardiac failure, chronic heart failure. Those are the patients with pleural effusions. Trauma patients with hemothorax, they can be easily diagnosed with the help of lung ultrasound. Pneumothorax can be diagnosed. Pulmonary embolism, not with the help of lung ultrasound mainly, but with the help of cardiac 2D echo, we can do that. USG guided procedures, thoracentesis, pleural tapping can be done with the help of lung ultrasound. So just a general idea, sternum here, anterior axillary line here, and posterior axillary line here. For the convenience of the use of the USG, we have divided in broadly into 6 areas. 1, 2, 3, 4, 5, 6. Yeah. And the landmarks are sternum, anterior axillary line, and posterior axillary line. However, what is the probe orientation? So when we want to look at pleural effusion, pneumothorax, those are the times we will be using curvy linear probes. Then we want to look at the artifacts of the lung ultrasound, that is the A lines, the B lines, we will be using linear probes. Yeah. Why linear probes? Because the A lines and B lines are the artifacts of the pleura. And the pleura is a very superficial structure. So better resolution and a very superficial structure. So we'll be using linear probe. So what is the probe orientation here? When you are placing the probe in such a manner that it is cutting the ribs, it is longitudinal placement. When it is along the ribs, it is transverse placement of the probe. Image generation on lung ultrasound. So this is basically a linear probe placed on in a longitudinal manner on the lung, and the image that is generated is in front of us, and these are the structures: the skin, the subcutaneous tissue, the rib here, which is, you see, rib is a bone. It is a very shiny structure, white here, and this is the pleura. Again, the pleura has to appear white here. Interpretation of the lung artifact. Correct. That is rightly said. See. Skin, sub-Q, ribs, this is all real. This is real stuff. What is there in the patient is clearly visible here. So from pleura and beneath, whatever is there is the artifact. So we also want to interpret the artifact. Lung ultrasound, initially, it was thought that air is a poor conductor of the ultrasound waves. So ultrasound is useless in lung. But gradually, over the decades, they have analyzed that understanding and interpreting the artifacts of ultrasound will help us differentiate a lot of conditions. Yeah. So lung line is a pleural line, which we saw, the bright structure. Shred line, in consolidation, there is sometimes shredding of that pleural line. A lines, what are A lines? Here we come. These are A lines. Long horizontal hyperechoic lines fading vertically, indicating reverberations at regular intervals, indicating the presence of air. The presence of A lines is a normal phenomenon. You see, this is the pleural line. So the distance from skin to the pleural line, this distance will keep on reverberating again, A line, again, A line, again, A line, and it will fade. These are transverse hyperechoic line. Now I will be showing you lung sliding. What is lung sliding? The to and fro movement of the pleura with each breath is lung sliding, and it is a normal phenomenon. Actually, this video was supposed to play, but so coming to no lung sliding, I'm sorry that I'm not able to show you the video, but the movement of the pleura here and there to and fro with each breath indicates lung sliding, and that is a normal phenomenon. If this pleura is stuck here and does not move with each breath, then that is problem. That could be endobronchial intubation, that could be mucus plugging or entire lung collapse, and that could be pneumothorax as well. So this is B lines. What are B lines? Sharp, razor-like hyperechoic lines arising from pleura and going to the end of the screen, indicating presence of water in the lung parenchyma. What could be the reasons for the water in the parenchyma? Pulmonary edema, consolidation, ARDS, anything. Once the B lines are there, the A lines are gone. B lines and A lines both cannot coexist. Yeah. Coming back to a scenario, till now we were studying the artifacts, the B lines, the A lines, the lung sliding. We were using the linear probe here. Okay. Here we are with pleural effusion or hemothorax. Here we will be using a curvilinear probe. A 40-year-old man comes to the emergency room with motor vehicular accident with following vitals. We can see the patient is hypotensive, tachycardic, desaturating, and tachypneic, and having a bruise over the right chest. The air entry on the right side is decreased. The moment you place your curvilinear probe on the right chest, this is the image you get. Fluid in the right pleura, diaphragm here, shiny bright structure, liver underneath it, the floating lung here, and lot of fluid here. In the setting of a motor vehicular accident, if you see fluid in the pleura, it is a no-brainer that this is hemothorax, and we would want to put a drain there without wasting any further time. Now coming to the last topic of the talk, RUSH, rapid ultrasound for shock and hypotension, assessment of undifferentiated shock. You are sitting in the ER, the patient has come in shock. You don't know the cause of the shock. We want to put the probe in these certain positions. First, we want to analyze the heart. The heart. Parasternal long axis view, parasternal short axis view, and apical four chamber view. Then we want to look at the IVC, whether it is dilated or it is collapsed. Then we want to look at the fast places, the right upper quadrant, the left upper quadrant, the suprapubic area. Then you want to look at the aorta. Why do we want to look at the aorta? Whether it is aortic dissection or whether it is abdominal aortic aneurysm which has burst or what. We want to rule that out also. And then we will have a look at the lungs. So now we will analyze as to how looking at these places. So the mnemonic for this is HIMAP: heart, IVC, Morrison's, aorta, and pulmonary. How, by looking at these areas, we will be able to differentiate one kind of shock from other kind of shock. The moment you put the probe on the heart and you see there is pericardial effusion with diastolic RV collapse, it is a no-brainer. This is cardiac tamponade. This is obstructive shock. And the only treatment in case of cardiac tamponade is pericardiocentesis as soon as possible without wasting any further time. You put the probe on the patient and there is right ventricular dysfunction. I am alerted. There is some possibility of massive pulmonary embolism or there is some pulmonary hypertension. I would want to put a linear probe on the femoral and rule out a DVT also in this scenario. We see LV dysfunction when we put the probe on the heart. LV dysfunction with a plethoric IVC, no-brainer, cardiogenic shock. LV dysfunction with IVC which is collapsing or normal. Yeah, I'll move further. I'll see if there is free fluid in the abdomen, if there is abdominal aortic aneurysm. If there is abdominal aortic aneurysm, yes, then you should look on the lines of abdominal aortic aneurysm rupture. If there is free fluid in the abdomen, it suggests fast positive, and then you want to see as to where the internal hemorrhage is, and the fast will take on from there. If all these things are negative with a normal heart, then think of other causes like sepsis, anaphylaxis, toxin, drugs, and dehydration. Yeah. One thing, where does lung come into play? Tension pneumothorax is one emergency causing shock in the patient, obstructive shock in the patient, which can be ruled out with the help of lung ultrasound. So concluding my talk, I would say that the use of ultrasound saves us time, saves us money, saves us radiation, saves multiple lives, and the more you practice, the better you become. But here is the caution. There is no risk in placing a probe on the patient, but there is risk in making decisions based on your USG assessment. Thanking you, all of you.
I think Shubhendu did a great job in the small time. And these are huge topics in intensive care. He has just touched the surface. And therefore, those surgeons wanting to venture into ultrasonography in the critical care surgical patients, it needs a lot of time, practice, patience, and a ready feedback from your intensive care people working in the ICU. I think I'll congratulate Shubhendu and the entire team for the packet that was given today. Thank you, Dr. Kapoor. I'll hand it over to the moderators.
Ravi, Anand, any closing remarks?
Yes, sir. Definitely. First of all, congratulations to Shubhendu for concluding a 2 days workshop in such a small time, with such a short notice. Basically, Shubhendu was just called a couple of days back, and he was ready with the presentation now. Sorry for the time that we took, 10-12 minutes extra, sir. But because of the technical glitch, we could not just help it. Definitely, these topics have been selected for surgical critical care specifically because we just need to sensitize the audience of Jaipur Surgical Tutorial on these salient topics that a surgeon needs to know whenever he came across a critically sick patient. Like we started with how to assess your patient in ward, who is going to sick, who is going to ICU. Right from that, initial assessment and then advanced assessment here. We'll go to the management and recovery part tomorrow. And I wish that we'll see more and more participation tomorrow. Thank you, sir. Over to you. Please, a few words, if maybe.
Anand Jain, you want to say something?
Thank you. Thanks to every speaker who has been here, took out the time after their regular schedule, and the chairpersons. Thank you. Thanks to all. And thank you, Kapoor sir, for giving us this opportunity to introduce critical care to the surgery residents. Thank you. Thank you, sir.
So once again, I would like to thank all the faculty and for your time and contribution. Tomorrow or at this time, I have a session in my meeting, so I may not be there. So I would like to thank everyone again. I would thank Ravi and Anand privately later. Thank you very much.
Thank you. Thank you so much.
Thank you, sir.
We will close. Yeah.